Welcome. It's Andrea Necchi from Milan, Italy. It's a great pleasure for me to be here today with esteemed colleagues to present you for the 5th year this year our annual European School of Urology course focused on the developments in perioperative immunotherapy for patients with bladder and kidney cancer. As I said, in each year, I have the honor and pleasure to deal with this course and with these issues with esteemed colleagues, Jens Bedke from the Department of Urology of Tübingen University of Tübingen, and Axel Becks from London, who will be hopefully able to join us at the end of during the discussion session. Unfortunately, is unable to be here for the presentation. We will hear a recorded video, and then hopefully we'll be able to discuss with him about the question and answer that may arise during the entire course. This is the agenda for today's webinar. We will start dealing with the developments and future directions of perioperative immunotherapy in bladder tumors in urothelial cancer with myself, and then we will see the pre-recorded presentation by Dr. Becks focused on the perioperative immunotherapy in kidney cancer, and then from Dr. Bedke we will hear about a few interesting and key clinical cases which will be focused on the management of patients with kidney and bladder cancer in the area of perioperative immunotherapy. I mentioned you that this webinar is accredited 1 European CMA credit upon completion, of course, of the questionnaire after the webinar. And it's important to know from your side that you are always able to launch a question throughout our presentation in the Q&A box. So please feel free to provide your questions, and we will be very pleased to answer the most burning question at the end of each presentation and during the discussion. So let's start with the first topic, which is the developments of perioperative immunotherapy in bladder and urothelial cancer. It's a really tough topic and a hot topic in this disease. So many new data have emerged during the last few months in this area. These are my conflicts. So this is a background, of course, if you well know the situation in terms of delivering a standard of care neoadjuvant chemotherapy is a bit complicated for many reasons, resulting in a poor adherence to guidelines for the majority of patients worldwide and also in the European Union, so that there is a clear need for improving the outcomes and improving the treatments and the adherence to treatments in these patients. This is a very busy slide showing summarizing the data that we have already gathered from phase 2 clinical trials using neoadjuvant checkpoint inhibitors alone or combined with other therapy, with chemotherapy or with other immunotherapy in the preoperative space of muscle invasive bladder cancer. The most important data that I would like to underscore here are related to the proportion of patients who achieved a pathologic complete response throughout these studies, which is pretty much in line with the data reported from the literature with the use of standard of care cisplatin-based chemotherapy, meaning that there seemed not to be any huge difference between single agent immunotherapy or combination immunotherapy, also involving chemotherapy in the preoperative setting. Of course, we also have initial very promising data related to the relapse-free survival data by using neoadjuvant immunotherapy, but of course here the follow-up of these studies is pretty short, so it's still the data are still immature and changing, so it's still difficult to envision a future based on this data as of today. But of course, overall, we clearly see that these numbers are endowed with a huge potential to shift the clinical practice in the near future by introducing immunotherapy combined with the standard of care, or instead of the standard of care. These are the initial data, as I mentioned, related to the relapse-free survival of the available data from the immunotherapy studies, the Nabucco study with ipilimumab and nivolumab, the Abacus study with atezolizumab, and the PURO-1 study with pembrolizumab. It's important to underscore here that in one case with Nabucco, the curve of relapse-free survival is related to the unselected patients, but we also gathered very important data recently from the Abacus study related to the ctDNA assessment of the patients, and in particular patients with a clearance of ctDNA after neoadjuvant immunotherapy. In the Abacus study, had an outstanding outcome after radical cystectomy, and in the PURO-1 study we showed already that Claudin low tumors assessed on the TUR pre-immunotherapy were associated with the best outcomes after pembrolizumab and radical cystectomy in this cohort. So in unselected or in biomarker selected patients, we may provide the patients with the substantial possibility to be cured from their disease. These are the studies that are ongoing today, large study, potential registration studies, most of which are randomized phase 3 studies comparing a combination therapy with immunotherapy and chemotherapy in cisplatin-eligible patients to the standard of care chemotherapy. So let's focus a little bit on a few of these studies. For example, these two keynote studies with pembrolizumab are two paradigmatic examples of studies involving patients who are eligible to receive cisplatin-based chemotherapy. And the 866 is a study combining pembrolizumab and cisplatin-based chemotherapy versus cisplatin and cisplatin-based chemotherapy and placebo. And on the other side, for a 905, we have the study combining pembrolizumab or pembro and enfortumab vedotin, and comparing these two arms to standard of care radical cystectomy arm, which is still the standard of care for patients who cannot receive standard of care cisplatin chemotherapy. It's important to mention here that as for the majority of phase 3 studies that are ongoing today, all these studies should be interpreted as a perioperative studies, including a neoadjuvant period, a radical cystectomy period, and the adjuvant period. So we are dealing with a fully perioperative setting here, not just a neoadjuvant, a preoperative or postoperative phase. So the point here is how to predict the response to neoadjuvant therapy and neoadjuvant checkpoint inhibition. Based on the data that we have already gathered from the literature, we know that, for example, the molecular subtyping is important to shape a potential for decision making and administering, for example, neoadjuvant chemotherapy in basal type tumors and neoadjuvant immunotherapy for Claudin low tumors. But all these data are shifting and are maturing based on the accumulation of further data. So we are still it's still a bit early to state the final word on the role of molecular subtyping in guiding patient selection. And also we provided the evidence recently that the molecular subtyping as well as biomarker in general may be shifting from pre-therapy to post-therapy. So another idea may be to provide a sequence of therapies that may be different according to the type of neoadjuvant therapy that is delivered by to the patients, and then envisioning a future in which the adjuvant period is delivered and is shaped according to the biomarkers that are assessed on radical cystectomy, that may be different according to the type of the previous therapy that is administered to the patients before radical cystectomy. Another key point is that related to the possibility to improving the outcomes postoperatively by improving the adjuvant period. And the key phase 3 studies involving immunotherapy have been conducted, most of which are closed, and two of these studies have been already presented: the IMvigor010, Ambassador study, and Checkmate 274 studies are 3 pivotal phase 3 studies comparing atezolizumab, pembro, or nivolumab versus placebo or observation, having disease-free survival, or in the case of Ambassador, disease-free survival and overall survival as a primary endpoint. All of these studies are addressed to the proportion of patients defined as having a high-risk muscle-invasive tumor. So the inclusion criteria are pretty much standardized in these studies. That included the patients with the PT2 or PT4 or N+ tumors after neoadjuvant chemo, or PT3, PT4 or N+ tumors after radical cystectomy alone. So pretty much similar populations, different comparator arms, in some cases observation, in another cases placebo, and different compounds, checkpoint inhibitors test adjuvantly. So let's see the data. The first data presented in this setting were the data from IMvigor010 with atezolizumab compared with observation. The data have been fully presented in manuscript early this year, a few months ago. The study was negative basically in all the endpoints in biomarker unselected patients and in biomarker selected patients according to the PD-L1 expression. It's clear from these Kaplan-Meier curves that the data did not result in providing a significant or a clinically meaningful difference between the two study arms. So the study was basically negative as conceived for the primary endpoint and for the clinical endpoint. Conversely, the data from the Checkmate 274 with nivolumab compared to placebo, in this case not observation, were quite positive in terms of the primary endpoint, the disease-free survival. We still don't have the data on the long-term overall survival endpoint, but based on this data that have been released on the New England Journal of Medicine quite recently, nivolumab provided a statistically significant and clinically meaningful improvement in disease-free survival in all comers, and even more in PD-L1 selected patients with an hazard ratio on 0.55, providing the evidence that it may be a new therapeutic options postoperatively in these patients. And in fact, nivolumab is currently under priority review by FDA and EMA as a potential new therapeutic option for patients with high-risk muscle-invasive tumors. It's important to underscore the fact that if you merge the data from these two studies, it's important to see the difference in the control arms. The control arms performed quite differently between the two studies, as it's clear here by including the curves from all of these two studies. And also, you can see here on the right side that the performance of nivolumab and atezolizumab seem to be quite similar. So it's at least in part a matter of the performance of the comparator arm, observation in one case and placebo in the other case, which resulted partly at least in the success or unsuccessful results of the studies. The most striking results coming out from the IMvigor010 study are related to the biomarkers, circulating tumor biomarkers, and ctDNA data were able to select the patients who were most likely to respond and to get benefit, survival benefit with adjuvant atezolizumab. So the ctDNA may be a biomarker to guide a therapeutic decision towards adjuvant immunotherapy versus no therapy in biomarker selected patient cases. So the clearance of a ctDNA after radical cystectomy is a very, very important point. This data may be potentially practice shifting. This is a stronger proof of principle of the concept of residual disease, a minimal residual disease in a solid tumor, and this data are being tested prospectively in another phase 3 study with atezolizumab, the IMvigor011. Additionally, which is the role of bladder sparing approaches, immunotherapy. The use of immunotherapy has revitalized the role of bladder sparing approaches. This year's ASCO meeting provided important data in terms of using immunotherapy combined with chemoradiation or immunotherapy or combination immunotherapy with radiation, with a substantially higher number of CR or bladder intact disease-free survival proportion at 1 year. So very preliminary data, but very intriguing data in terms of the possibility to spare the bladder for the majority of patients. And pivotal phase 3 studies like the Keynote 992 or the SWOG study with the Pembro and the atezolizumab respectively are currently ongoing and potentially setting new standards in this area. There are, of course, studies that are using the therapeutic choices sequentially. So chemoradiation as induction followed by immunotherapy. These are 3 studies, pivotal studies in this regard that are running worldwide, mainly in the United States. And finally, there is a new concept raised with the use of new drugs like immunotherapy. So the possibility to spare the bladder or spare the bladder to spare any radical local therapy delivered to the bladder, including radiotherapy in selected patients. The initial data from the retained bladder study provided the evidence that administering neoadjuvant and back chemotherapy and RTOR and in patients with achieving a clinical complete response, active surveillance may be an intriguing choice, and early data are suggesting that it may be a choice within clinical trials, and even more in patients harboring any the gene alteration together with the clinical complete response. These patients may have substantially high proportion of substantially high possibilities of achieving a cure a long term, but this data, of course, need confirmation with further studies. And of course, we have data from a recent study by Galsky with the combination of nivolumab and gem-cis, providing the evidence that 1 year bladder intact disease-free survival in patients achieving a complete response after immunotherapy and continuing with the nivolumab alone instead of any other treatment were very promising, although of course pending confirmation with further studies. So in conclusion, in muscle invasive bladder cancer, the pathological response rate with the neoadjuvant immunotherapy are very promising. But if we need to spare the patients any radical local therapies, we need to. So if our aim is to rise further the bar towards achieving a bladder intact survival, probably we need to achieve a bit more in terms of pathologic responses compared to the data achievable with single agents. The most important point raised by the use of immunotherapy are related to the revitalization of the perioperative space, including the adjuvant space, the use of the emergence of circulating tumor DNA as a biomarker for patient selection, and the possibility to question in the role of any radical dual therapy, not only radical cystectomy, but the radical radiotherapy in very selected patients. So this is the landscape of the spectrum of the data that are moving close to the routine clinical practice. So let's see if we have some important question from the audience. So we will be able to answer some of these questions. Perhaps Jens, you may. If you like, you may see if there is some important question we may address in this space. Otherwise, we will move on.
Yeah, maybe one question here at this point. So the question is immunotherapy indicated in altered renal function? So how do you deal with that if renal function is altered? How do we do that?
Okay, so basically the data that we have seen with immunotherapy, for this data, the driver was the cutoff of renal function that was historically associated with the use of neoadjuvant cisplatin-based chemotherapy in order to decide whether using immunotherapy alone or combining immunotherapy with chemotherapy. Regarding use of immunotherapy alone, so for cisplatin eligible patients, we have a substantial literature suggesting that we may lower the cutoff of GFR in order to deliver immunotherapy, at least in a single agent. So we have experience in delivering neoadjuvant immunotherapy and neoadjuvant pembro also in patients with the GFR of 20 or even just below 20 safely. So of course, what I would suggest in all of these cases is to have a multidisciplinary management, including a nephrologist, together with us when delivering treatment.
Okay, I just checked the chat, so I think we can move on and save some questions for later on for the discussion.
Great. So I leave the word to you for sorry, we leave the word to the Axel Becks for the pre-recorded session, and we hear from him what is going on regarding the perioperative space of renal cell cancer. So we can start with the video.
I will talk the next 15 minutes about old paradigms and next destinations of perioperative immune checkpoint inhibition in kidney cancer. This is a very interesting field and rapidly developing. And I apologize for the fact that I'm giving a pre-recorded talk. This is for logistical reasons, and I hope that I will be able to join the discussion at the end of this presentation. Now, this is my conflict of interest. Let me start with the previous situation we had in the era of targeted therapy. This talk is on immunotherapy, but it is absolutely vital that we understand what went ahead before we actually changed the immune checkpoint inhibitor targeted trials for adjuvant therapy. So all these trials have been performed. There's one with a mammalian target of rapamycin inhibitor, that is Everest, which has not yet reported, but only Astrac was a positive trial. And because there was this discrepancy between the fact that there's only a prolongation of disease-free survival, but not an effect on overall survival, with a high rate of treatment-related AEs, this trial was not approved. And that is one of the reasons why the EU guidelines eventually decided not to recommend any of the VEGFR-targeted therapies in high-risk renal cell carcinoma. And this is based on the systematic reviews and intertrial meta-analysis that were performed that basically showed that the cumulative hazard ratio for these trials was 0.89, and there was no overall survival benefit. But these trials also taught us other things. And one of that is, if you have an absence of overall survival signals and you do not have any improvement in quality of life, indicating that the drug prevents symptomatic progression, then these trials will probably introducing the danger of radiological window dressing. So what do I mean with this? You can imagine that patients, when they are on follow-up or on placebo, will probably develop recurrences. Very often these recurrences are non-symptomatic and they will be visible on CT scans. And if the trial that was performed only leads to a prolongation of that recurrence occurring in the asymptomatic visible phase, you may ask yourself, what did you actually do here? What you would like to see is, in the absence of overall survival, that you at least delayed symptomatic progression. And these trials have not shown that. But what these trials definitely showed is, because the comparator was placebo, that there was a high rate of grade 3 to 4 adverse events. And even in trials like PROTECT, which was investigating pazopanib, or ASSURE, which was investigating sunitinib and sorafenib, there were only few patients who tolerated full dose or either discontinued when they received full dose. What we also know is that there is overtreatment of these patients. Observation of the placebo arms show that at for example, 4 to 6 years down the line, still 40 to 60% of the patients have not had a recurrence. So that is something which is completely different than in the metastatic setting. And some patients will suffer side effects from these treatments and have no benefit at all. Now, with this change with the ongoing adjuvant immune checkpoint inhibitor trials, this is a very busy slide. In the sake of time, I cannot go into detail of all the ongoing trials, but I would like to draw your attention to the fact that 5 of them are ongoing. There's another one which is missing on this table, which is Rampart. It's the UK-led trial, which is very similar to Checkmate 914, investigating durvalumab and tremelimumab versus durvalumab monotherapy versus observation. However, we have one trial that reported, that is Keynote 546. That is a trial that was investigating pembrolizumab versus placebo in high-risk patients of recurrence. And if you have a closer look at the indication, the eligibility of this trial, it was cleverly designed. They allowed, out of a clinical unmet need, patients who were resected to no evidence of disease after metastasectomy. The only thing is, in that study, they allowed patients into the trial only if the metastasectomy occurred in the first year after nephrectomy for curative intent, or synchronously. I think that was very clever from a statistical endpoint, because most of these events are driven by high-risk disease. And by doing so, by including this very high-risk subgroup of patients, it is, from a trial strategic perspective, very clever. What we can see here is that this resulted in a hazard ratio of 0.68 for the entire study group by ITT population, and the primary endpoint was investigator endpoint, so not by central review. Again, as I said, 5.8% of these patients were resected to no evidence of disease with metastatic single sites and oligometastatic disease. And we can see then, if we look at these exploratory forest plots, that especially the subgroup is driving the event rate. And that is something we need to question here. The study is still positive when we look at the M0 subgroup. It's still an 0.74, but it's only on disease-free survival. Please don't forget that. There was an earlier overall survival signal, but this has no statistical significance at the moment and may just be driven by this M1 NED population. And there are very good arguments to actually exclude them from metastasectomy. You may be aware that we have some metastasectomy scores, and they say that if patients recur with the disease in the first year, that this is one of the prognostically poor factors. We also have some data here looking at, for example, lymph node recurrences. There is one paper that looked at resection of isolated 1 to 3 lymph node metastases in the retroperitoneum in 138 patients from Bradley Libovich's clinic here, the Mayo Clinic, and Gershman published it. And the median time to development of distant metastatic disease was only 4.2 months. And again, here in a smaller series of 50 patients, those who recurred after surgery within the first year had a disease-free survival of only 12.3 months when their lymph nodes were resected, as opposed to those who had 47.6 months when they recurred more than 1 year after the primary surgery. So there's certainly something to bear in mind, and whether this becomes standard practice is very, very questionable at the moment. Another trial which is ongoing, which I would like to mention, is not because I'm a PI on this study and in the steering committee, but it's simply because it is interesting insofar that it is one of the 2 only trials that investigate immune checkpoint inhibitor combination therapy. Because the combination of ipilimumab and nivolumab is fairly toxic, they reduce it to treatment of only 6 months, and they give a flat dose. So it's a modified dose, and they've recently introduced a nivolumab monoarm. I think that's very clever, because you can imagine that the approving authorities like FDA and EMA will very closely look at these results, and they might question the efficacy and the significance of these findings if there wasn't a monotherapy arm. Now let's move to the rationale of neoadjuvant therapy, there's this idea of downsizing and downstaging. And these are interesting concepts, especially for surgeons. Can we improve surgical approaches here? Are some patients amenable for partial nephrectomies? This has been looked at in the era of EGFR targeted therapy, and basically the findings are disputable. I think the most important aspect at the moment is translational research, because these trials give us an opportunity to understand what is happening in the tissue after pretreatment. And frankly, the latter rationale here, improve outcome parameters, would require a randomized controlled trial, which is currently not ongoing, although I have to admit that the PROSPER trial, which is investigating nivolumab versus observation as an adjuvant therapy, also has a short neoadjuvant lead-in time of 4 weeks. Now, this trial is still ongoing and is pending results. This is an example of one of the few neoadjuvant trials which is currently ongoing, that is performed at the NKI in the Netherlands. We are short of 3 patients before completion. This is investigating the combination of avelumab and axitinib. I think a very interesting compound, which unfortunately has not shown an overall survival benefit and therefore didn't make it into the guidelines, but there is a progression-free survival benefit in the metastatic setting. And that's also what we are seeing in patients with high-risk disease. The eligibility is a combination of clinical CT and M staging and biopsy-proven grade. Now, this is an example of a patient who took part in this trial. You could see the shrinkage of the primary tumor in the lower panel, and also the lymph node positive disease disappeared. And that is something which we are seeing across the patients who have currently been included. And the interesting is, not all patients respond, and this dichotomy will allow us to investigate why there is a response in the primary when we look into primary tissue. And there are very good examples that came out recently for only very few patients investigated. This is, for example, a cancer cell paper here on 6 patients who were treated with their primary tumor in place with checkpoint blockade. And then they did single cell sequencing of CD8 T cells and found that there is obviously a sort of cooperation between tumor-associated macrophages and terminally exhausted CD8 cells that would explain why some patients have a complete regression in the primary tumor and others don't. And we have to follow suit in these concepts, because this is the only way to understand the mechanisms and resistance of disease here. Now let's move to primary metastatic renal cell carcinoma. You may be aware that we had evidence in the era of targeted therapy with sunitinib from Camina and Certime, and it made it into the guidelines that patients who require systemic therapy should be treated with their primary tumor in place. Now, this has been superseded with more effective therapy. Currently, there are studies ongoing which are looking into the potential benefit of a deferred cytoreductive nephrectomy after patients have been treated with immune checkpoint inhibitors. In the interim, however, we do have data, and they stem from these primary or the pivotal trials that have been performed. This is a table that shows you an overview here. The percentage of patients who have been included into this trial with their primary tumor still in place ranges in between 11.4 to 30%. And what we see across the board is that there is an improvement of progression-free survival and overall survival if these data were available in comparison to sunitinib. So in my point of view, there's a very good argument to follow suit with this guideline recommendation and treat patients with their primary tumors in place with immune checkpoint inhibitors. And we were analyzing recently a series of 40 patients, which we have now extended to 71 patients who were treated with ipilimumab and nivolumab and their primary tumors in place. And this waterfall plot clearly shows you the bars of the reduction of the primary tumor, but the color code means that yellow, there's a partial response at metastatic sites, blue, a stable disease, green, a complete response, and red, progressive disease. And what you see is very similar to what we already saw in the era of EGFR targeted therapy. If the primary tumor responds, you're very likely to also respond at metastatic sites. And now with this retrospective series maturing, we see that we have a 10% complete response rate in primary tumors. And we have performed about 20 cytoreductive nephrectomies, with 3 of these patients having complete pathological responses. So watch this space. I'm very sure that advancements will be made in the future in this era. So let me sum up, and I hope we have a discussion at the end. The EU guidelines do not recommend any of the investigated VEGFR targeted therapies for adjuvant therapy. Patients who are interested can take part in adjuvant immunotherapy trials in several European countries. Checkmate 914 is still ongoing. Rampart is ongoing in the UK and in France. The first adjuvant immunotherapy trial, Keynote, has reported and may be practice changing if approved by EMA. Neoadjuvant immunotherapy trials are ongoing and may help to define mechanisms of resistance to therapy. But ultimately, we need neoadjuvant therapy to be tested in a randomized trial against the new standard of care, which may be adjuvant immunotherapy. And I'm very sure that these trials will be soon developed. And finally, upfront systemic immunotherapy in primary metastatic renal cell carcinoma with the option of deferred cytoreductive nephrectomy is a valid option and the legacy of Camina and Sertan. I thank you very much for your attention, and I hope we can take questions at the end. Thank you very much.
Okay. Okay, great. We received a few questions. So just to target one question prior to move to Jens' presentation, one question is about the role of immunotherapy in patients with non-clear cell renal cancer. And I would say that we have data in a metastatic setting, of course, and not properly in the perioperative setting, in particular with by using immunotherapy in combination therapy, and the data from basket studies, in particular in basket studies including ipilimumab and nivolumab and cabozantinib, nivolumab and cabozantinib seem to be promising also in patients with non-clear cell histologies. And also we have the data on cabozantinib from the SWOG study led by Montipalli in metastatic setting. So we'll see whether there would be additional option for moving in earlier disease settings with these non-immunotherapy drugs in these patients. So I would say that it's the case to jump to the third presentation. So it's truly a pleasure and honor for me to introduce Jens Bedke, who is my partner since the very beginning of this course. So since the first course we held in London in 2017. So it's a really pleasure for leave the word to him, detailing the clinical cases in the context of perioperative immunotherapy. So please, Jens.
Andrea, thank you so much. So I think if we are looking at the past 5 years and how this field has evolved, we have to report news for every year since this course is ongoing. So it's a pleasure now to share some of the cases in this respective setting. So, it's a clinical case series of patients in the perioperative setting with the treatment of immune checkpoint inhibitors and bladder carcinoma and renal cell carcinoma. So these are my potential conflicts of interest. And just let's jump to the first case. So the first case is in the setting of cisplatin eligible bladder carcinoma. So it's a female patient whose age was 76 years old, and you have to look at quite some years back, April 2018. And this patient had an incidental finding of a mass in the bladder, and she had a hydronephrosis of the left kidney and the axial imaging, and all this done due to the clinical symptomatic arteriosclerosis she had. And then she underwent a TURB and got a double J at the left side, left kidney, and the histology was a TCC, transitional cell carcinoma of the bladder, at least a T2 tumor of high grade. And these are the pictures from the initial staging, which she received because of her arteriosclerosis. So the left kidney, hydronephrosis, you have the tumor here on the left bladder wall, in the coronal section, and also on the axial section. So, well, these patients had some secondary diagnosis. So, as I mentioned, arteriosclerosis, it is a peripheral occlusive artery disease, the stage 2B of both lower leg and the planned recanalization. We are here still in the year 2018. So, had arterial fibrillation, got oral anticoagulation, was a former smoker, with some heart failure, mitral regurgitation, grade 1. And she was operated in the abdomen post-sexual post-appendectomy. So the question for us was, what would you do in this setting? Just again, as a reminder, you got the site diagnosis, secondary diagnosis, the tumor here on the left wall, the hydronephrosis, and the question, should we do cystectomy? And should we do cystectomy with neoadjuvant chemotherapy, yes or no? Well, and at the end of all what we have discussed, the patient refused the cystectomy. So we discussed it intensively with her, and she said, no, 76-year-old female patient, no, I don't want to go to cystectomy. And so we start GEM-CIS with pembro. So she was confident in doing a chemotherapy and do pembrolizumab in combination. And then after the 2 cycles of GEM-CIS, we had to hospitalize her due to adverse events, a reduced performance status of fatigue. She had some thrombocytopenia after just 2 cycles. Well, just to give you the impression, what has happened in between of these 2 cycles. So this is May 2018, 2 cycles of GEM-CIS plus pembro. And what you observe is that here at the left orifice, you have the bladder wall, the tumor had a partial remission. And this went on. We continued the pembro as a second line or as a further line in this patient from August 2018 up to November 2018. And again, the partial remission on the left bladder wall, which is still ongoing with the administration of pembro now as a monotherapy in the setting of a patient who is eligible, cisplatin eligible. Once again, just to give you the impression, initial baseline here, May 2018, November 2018, left bladder wall, the double J is still in place, and we have March 2019, so nearly 1 year later. And what you can observe, I think it's quite interesting to have a look here at the hydronephrosis of the kidney, which I think totally resolved. So here the double J is still in place, but have a look at the perfusion of the kidney parenchyma. And here the stent is removed. So we could remove the stent. And this was in January 2019. We did a retrograde evaluation. And we saw that the tumor is not, that the debulking of the tumor by the pembro has led to a free flow from the urine from the left kidney into the bladder. And we could successfully remove the double J. So how does the case went on? In March 2019, sorry for that, we had the 11th cycle of pembro, and the patient developed a symptomatic pneumonitis. And these are the images just to give you an impression how a pneumonitis looks like in the CT image. So she was short of breath, had some dyspnea. We did the CT scan, and here you have these, milk glass infiltration, which is a characteristic sign for an immune checkpoint inhibitor-induced pneumonitis. So what we did, we discontinued the pembro, had to start a high-dose steroid therapy, which we tapered on the in a few weeks, and then the patient was without any treatment. And the last follow-up we got was in August 2020. So it's more than 2 years after the onset of this treatment. Still with a complete or nearly complete response in August from August 2018 to August 2020. What we did in between is we did a TURB evaluation and did a resection and a random biopsy from the bladder and detected no tumor in this patient. So she had a bladder intact-free survival with histology proven complete remission in the bladder. Let's move on to the second case. It's now a case in the also bladder carcinoma, the cisplatin ineligible situation, and again a patient who received a perioperative immune checkpoint inhibitor. Now we are actually in the year 2021, started December 2020. The patient had a cystoscopy due to the urgency. You know, it's a male patient, age 73, so enlarged prostate, BPH, some urgency. And the office urologist did a cystoscopy due to the urgency, and he detected a microhematuria. And in the cystoscopy, the patient had a bladder wall, the mass at the bladder wall, which you can see here in the following CT scan. And this was diagnosed and secured by histology with a TURB. So it's a transitional cell carcinoma, high grade with concomitant CIS, and at least a T2 tumor on the anterior right bladder wall. Again, the contrast images of the bladder filled, you see the sparing of the contrast on the bladder wall. So what we did, the patient had a creatinine of 0.7, GFR was 110, performance status very well, but he had a hearing loss of grade 3, according to the CTCAE gradation. Again, the blick at the TURB, the view of the TURB, so here you have the tumor of the patient, solid, some papillary formation. So what we did, shall we do immediate cystectomy, or did we perform a neoadjuvant treatment? So the patient was not eligible to cisplatin administration because of the hearing loss, grade 3. And he was included and received 3 cycles of pembrolizumab as an upfront therapy. So this is the baseline. And after 3 cycles of pembro, this was in May this year, the patient had nearly a complete response, a visible complete response in the CT imaging, and then underwent cystectomy with a pelvic lymphadenectomy and an ileal neobladder formation. And the final histology of the patient after removal of this bladder after cystectomy was a PT0, so he had no lymph node involvement, and he had an incidental prostate carcinoma, intermediate risk, Gleason score 7A. Let's move on to the third case. In the third case, now we are moving to renal cell carcinoma, high-risk renal cell carcinoma. And again, a patient who received in the neoadjuvant setting immune checkpoint inhibitor combination. Again, it's a female patient, 73 years old, and we are going back to February 2019. So she had a renal cell carcinoma of the right kidney with a caval thrombus. An infiltration of the liver could not be ruled out, in addition to an infiltration of the colon ascendens. And what also you here have the coronal imaging, the renal tumor, the extension into the caval vein, and the patient had a pulmonary embolism with a right heart strain. So she was impaired in her right heart failure, and thereby she had got an ECOG performance status 2, dyspnea, and needed oxygen. And you have some imaging of the pulmonary embolism here centrally located in the centrally veins. And this was why she was not approved for surgery. So our anesthesiologist in the interdisciplinary discussion told us that she will have a high risk of heart failure due to the impairment of the right ventricle of the right heart. So what we did is we started dual immune checkpoint inhibition with ipi/nivo in March 2019. This is the baseline picture again of the patient with the pulmonary embolism. So what happened? After 2 cycles of ipi/nivo, the patient developed the hepatitis, and here you have the course of the liver enzyme elevation after 2 cycles, about 230, 240, 330, and she received steroids, and this resolved very, very quickly under the steroid therapy, this hepatitis. But we decided not to go on with the 2 cycles of ipi/nivo and did due to the steroid therapy, and we observed a spontaneous arterial tumor bleeding in this patient. So you observe here in the arterial phase, you have here the bleeding in the tumor. Once again, the contrast enhancement in the arterial phase, the aorta is contrast filled, and you had a tumor bleeding, probably maybe induced by the steroid therapy, maybe induced by the immune therapy. We could not, well, we can discuss the cause and maybe your experience of that. So the patient underwent a coiling, intervention with a coiling of the renal artery. How did that went on? So after that, we observed a consolidation of the tumor, a lot of necrosis. Here you have the coils in the renal artery. And finally, we had a reduction in the size of the pulmonary embolism. So the pulmonary embolism resolved, and now she had normal pulmonary arterial pressure. Well, Finally, the patient underwent nephrectomy, cavatomy, removal of the thrombus, adrenalectomy, and the histology proved a clear cell renal cell carcinoma with no, well, let's say, vivid or detectable tumor cells, still live tumor cells. This was staged as a T0 tumor after the nephrectomy with the removal of the caval thrombus. Last follow-up of the patient was in this year, June this year, so she's still free of metastasis, clinical M0, N0 in the last follow-up of the patient. Now, last but not least, the fourth case. And the patient, again, of clear cell renal cell carcinoma, a PT3B tumor, again extending into the caval vein. And this patient received an adjuvant checkpoint inhibitor. So it's a male patient, very young, 59 years old, dating back to February 2019. It was a biopsy-proven clear cell renal cell carcinoma. You have the extension into the caval vein, clinical PT3B, the primary tumor observed here extending from the kidney, and the patient underwent nephrectomy, caval thrombectomy, and was then staged as M0, N0, and a PT3B. And this patient started an adjuvant pembrolizumab treatment for 17 cycles or placebo within the trial. And this patient is still in the 24-month follow-up disease-free survival, so no metastasis and still not negative alive. So I really appreciate that I had the chance to present you these 4 cases in the different clinical scenarios of the perioperative immune checkpoint inhibition. And well, I'm happy to discuss the questions right now with you. Thank you so much.
Thank you, Jens. Really interesting cases. So we received a lot of questions. Just a question to you from the many that we received. A question about the need for a radical TURBT. That, for example, focusing on the second case. So we need to underscore the fact that in any case, and in particular in cases with the need for trimodality therapy, we need to perform when possible, whenever possible, a radical resection of the primary tumor, and then viewing the systemic therapy as adjuvant therapy combined with radiation. So this is a comment more than a question that we received. And then let's see if there is any burning question that we may address at this stage. There is a question related, let's see, to the role of endoscopic resection after any, or to assess any response to systemic therapy or to systemic therapy and radiation. What would be your view regarding the need for evaluating endoscopically a resection after any treatment in order to decide how to move forward instead? And then I would add to this question, instead of using, for example, radiological assessment alone, without having any histological assessment. What is your viewpoint regarding radiology to assess response or to stage a tumor versus radiology and histological assessment?
Yeah, thanks for this question, Andrea. I think it's depending of the way you go. So if you're doing neoadjuvant chemotherapy or a neoadjuvant immune checkpoint inhibition prior to an intended cystectomy, I think you can rely on the axial CT imaging, or if you would like to be more accurate, you can do an MRI and do a virus grading to evaluate the bladder wall. But finally, after this step, as the pre-treatment with the neoadjuvant phase of immune checkpoint inhibition, either alone or in combination, if you decide that the cystectomy will eventually will follow. So I do not think that it's mandatory to redo a TURB. And in addition, I think if you have a solid mass and a mass which is extending into the bladder wall and by imaging beyond the bladder wall, it's impossible to remove this mass completely. I mean, if you have in the imaging a CT3B tumor which extends over the bladder wall, and this was the case in the patient who received 3 cycles of pembrolizumab in the neoadjuvant setting, you will not be able to remove the tumor completely by TURBT. In addition, I think if you're doing cystectomy, and this is my own experience, if you have done deep resections, and if you have patients where somebody had a bladder wall perforation due to the TURBT, this makes the surgery more difficult with regard to nerve sparing, and especially also to the potential tumor cell splitting. So to summarize that, I think it's not mandatory to perform a complete resection in TURBT if you intend to go for cystectomy and a neoadjuvant strategy. If you're going for trimodal therapy, that means radiotherapy, the TURBT, and the complete resection by TURBT prior to radiotherapy is a mandatory and a prerequisite, but it's another strategy, the trimodality.
Great, I fully agree. So I would suggest to launch the polling question while we will wait and see if Axel will be able to join the discussion. Let's launch the polling question to the audience and see what will be the answers. So let me share my screen. Okay. So the first question that I have to the audience, I have to you, is related to the role of adjuvant therapy and the decision towards adjuvant therapy in patients with muscle-invasive tumor. What would be your, based on the data that we have, the preliminary data from trials, again, nothing again as a routine practice, but from trials, what would be your first or your preferred choice based on the data that we have today, June 22nd, 2021? Adjuvant nivolumab in unselected patients. Second choice, adjuvant nivolumab or atezolizumab equally. Or third option, nivolumab in PD-L1 high patients alone. Fourth option, nivolumab in PD-L1 high patients and equally atezolizumab in ctDNA positive patients after radical cystectomy. Or last solution, none of the above solution. We need more longer term follow-up. We need, in particular, we need overall survival data. So please vote. I'm not sure if we'll be able to see just now the results, so we have to move forward. Let's see. Let's wait a little bit. Otherwise, let's jump to the second question, to the second poll. Oh, let's see. These are the results. So basically the 37% of the people voted for adjuvant nivolumab in PD-L1 high or atezo in ctDNA positive patient. That's interesting. People are waiting the data, the full data, but they are considering very deeply, with deep attention, the data on ctDNA as a biomarker for atezolizumab. So it's a way of revitalizing atezolizumab data. 20% we have to wait. 27% nivolumab in PD-L1 high, 15% nivolumab in unselected, just 2% nivo or atezolizumab. So interesting results. So let's see the second poll. In patients with high risk renal cell cancer, would you perform adjuvant checkpoint inhibition if the risk of relapse is decreased by what amount? 10%, 20%, answer C, 30%, 40%, or 50%. Please vote. So it's a burning, of course, a burning question that they have to deal with with the routine practice, so the translation from clinical trials into routine practice to the adherence of any potential new therapeutic option to clinical practice. Let's see if we have the results of the poll. Let's wait a few seconds more.
I think, Andrea, for the poll, we have also got to the second and third question before we close the poll and see the results. So maybe we can also go on for the second question. So if you would you consider this treatment if an overall survival benefit is not observed? So would you just rely on DFS, then click yes. If you say, well, no, I need overall survival benefit to be shown, then you have to click on no. And the third question is, what is your acceptable, your personal threshold of treatment-related adverse events of grade 3 or higher? So these are the adverse events which needs treatment, stop, interruption of therapy, and considering the risk, the relapse risk you gave above. So what is your acceptable side effect rate? It's 5%, 10%, 15, 20, or even 25%. So please vote now. And I think if we give just another few seconds for the voting, we can go to the results, which will be really interesting.
Yeah, all the points that have to do with the real world, actually. Yeah. So let's see. So the adjuvant checkpoint inhibition is would be the treatment of choice if the risk of relapse is decreased by 30% for the majority of the attendant people, 30%, 36%, I'm sorry, decreased by 30%. Second choice at 20%. So Jens, could you please comment a little bit if you agree on the majority of the people that answered 30% as a reliable, as a suitable cutoff?
I personally think it's a suitable and reliable cutoff. Maybe all the audience has listened very carefully to Axel's talk where he presented the keynote 564 data, which gave an hazard ratio of 0.68, which is nearly the 30% reduction. This answer is in line of the keynote data, but I think it's of interest that this threshold, so let's say one third of the hazard ratio should be improved. I think it's in line. It's also in line with my personal opinion.
And let's see, importantly, if the 30% risk of relapse, the decreasing risk of relapse will translate in OS improvement also. So another issue is the relationship between the decrease in disease-free survival, the decrease in the relapsing risk, and the decrease in dying from the disease. So the relationship between DFS and OS is still very complicated in some cases. Regarding the question, let's see, what will consider the treatment if an overall survival benefit is not observed? The majority responded no, 59%. So not so many. I thought more people would have responded no. 41% responded yes. So not necessarily for 41% of the people attending, we not necessarily need at least an overall survival benefit. So probably people are also interested in the quality of life outcome and in safety of treatment. And the third question, what is your expectable threshold for over-treatment related to the adverse event of grade 3 or 4 or higher, considering the relapse risk above? The majority voted for 15%, 30% of the audience, and then 10%. So Yes, a quick comment on this result.
Well, yeah, I think it's very close together. So it's between 10%, 15%, 30%, 28% of the participants got in that direction. I think even the 5% answer has a high count. So for me, this answer points in the direction, well, we have the need of an adjuvant therapy, an adjuvant strategy. We would expect a decrease by about 1/3 of the hazard ratio as an improvement, but this therapy should have, well, minimal or only very, very limited side effects, which should be in the range of, yeah, let's say 10% in the middle, 10% maximum, 15%. I think this is a very strong signal that our audience needs or seeks for this adjuvant therapy, but that the medical need is in the adverse event rate and the adverse event management probably.
Great. So I have a general comment regarding the data that we have presented and the way forward that we have hypothesized based on the data, which is pretty much pessimistic about the role of immunotherapy, because in my feeling, at least for bladder cancer, we may have a second wave of next generation compounds that may be somehow even more promising than immunotherapy. And I'm in particular dealing with ADC or in molecularly selected patients FGF receptor inhibitors. So it may be that in the next editions of our course, we will speak more on the use of non-immunotherapy compounds in the perioperative setting. So what is your feeling regarding what is going on behind the corner, at least in bladder cancer, in the non-immunotherapy world, that may have a huge impact on the way we currently manage immunotherapy throughout the clinical stages?
So I think, Andrea, this is definitely of interest, how this field will move forward after the era of the immunotherapy. And I think that one of the next steps will be not really moving away from immunotherapy, but improving immunotherapy by maybe the modulation of the tumor microenvironment. And just thinking of the IDO inhibitors, just thinking of cytokines, the pegylated interleukin, the Nectar-214. I think there's a lot of music in here. And what I do not know, I think you presented very nice data on the cDNA profiling the minimal residual disease and the characterization of that disease state actually. And the question for me will be, how will we incorporate the NGS sequencing and define very high risk subgroups in this perioperative setting for bladder carcinoma? I think there's a lot of clinical need which we have here.
Yeah. And also the applicability in routine world of genomic testing, and in particular in the perioperative space where the timing is crucial to play the major possibilities of saving lives is not quite easy to manage. I totally agree. And my second consideration is about the role of combination therapies in renal cell cancer. So what is your feeling regarding the potential way of changes that may occur in the perioperative setting with the use of combination therapy? So IO-TKI combinations, would they be endowed with the potential of shifting further the prognosis towards even more promising results compared with immunotherapy alone when used perioperatively in your view?
Well, I think if we compare the renal RCC, if you compare RCC to bladder, I think it's totally different, because on bladder we have great concepts of doing perioperative concepts of neoadjuvant chemotherapy, neoadjuvant immune checkpoint inhibition or combination, and then followed by the adjuvant phase. And if you compare that to RCC, I mean, in RCC, we are totally lacking any of these. So now we have the first thing on the horizon with an adjuvant, positive trial of an adjuvant immune checkpoint inhibition. We do not really have data for neoadjuvant therapy in renal cell carcinoma. So was very great to hear from Axel that the NeoVax trial will finish recruitment soon and that we get results from this setting. I think in renal, we are more advanced in the metastatic setting, giving upfront TKI or TKI-IO combinations. And for the TKI-IO combination, there's prospective data is still missing here. Well, you explicitly asked me for the TKI-IO combination. So I think what we have learned is all from the phase 3 trials from the metastatic setting. And what we know from the metastatic setting is that the primary is responding to TKI-IO combinations. And this is a very strong and important signal because we learned from TKI monotherapy that TKI monotherapy is very effective in the metastatic setting and metastasis, acting on the metastasis, but it's not really active in the primary. And maybe you remember the trials of the caval thrombus downstaging by TKI monotherapy like 7-8 years ago now, that we did not observe really a great effect. And if you now go to the TKI-IO combinatory trials and compare the primary, and we observed here that the primary showed reduction in tumor size based on this TKI-IO combination. And this offers new opportunities in the operative setting. So patients who were considered not suitable for surgery due to tumor extent or not suitable for nephron-sparing surgery, I mean, the upfront treatment with a TKI combination is really an option right now.
Great. So we have run a little bit late, 10 minutes late. So I think it's time to closing the doors. I remember the audience that the content of this webinar will be available on the ESO YouTube channel within 48 hours from now. That said, I would like to thank my esteemed friends and colleagues, Jens and Axel also, for having provided us with such a huge discussion and presentations. It has been really an honor for me to participate with you and to make this course with you. And of course, I would like to thank the fantastic staff of the European School of Urology for assisting us and making us everything leading so smoothly, so in this fantastic way. And finally, of course, we would like to thank you all for your very nice and fantastic attention and the presence. You were so many, but outside of the virtual meetings, let's see if we'll make the possibility of having an in-person meeting the next year for the next year's version of our course. So see you hopefully next year in person for the next meeting during the EAU. Thank you. Have a great evening and see you next year.